All right, good morning. We're going to go ahead and get started. Can everybody see my slides okay?
Yes.
All right, cool. Sorry, there were some new settings on Teams this morning, but everything's set up and recording, and hopefully everybody will be able to come into the lobby without it making that chirp sound every 5 seconds or whatever. So today we're going to talk about two different things that are kind of closely related, and then we'll finish up talking about a couple exam questions you guys had to hopefully get those answered for everybody. So the first thing we're going to do is talk a little bit about surgical quality improvement. And this is an important topic, not only because it improves patient outcomes, but it also affects your bottom line. We're seeing a lot of groups are tying patient outcomes to bonuses, pay raises, and ultimately it goes into the survivability of your group and the hospital itself. If you have poor surgical outcomes, there's a tendency to bring in anesthesia groups that don't have bad outcomes because the federal government ties your funding to it. So if you have somebody that goes in to have a lap chole done, there's a kind of a bulk payment for it, and I'll just say $5,000. And that's whether the patient goes into the hospital and comes out the same day, 2 hours later, or they go into the hospital, have complications, an infection, what have you, and wind up spending weeks there. So there's obviously an incentive on the part of the group as well as the facility to kind of minimize expenses and maximize profitability by having them in and out as fast as possible or within a reasonable amount of time. So part of that is tied to specific core measures that we're going to discuss here. So SCIP, or the Surgical Care Improvement Project, it's been a long-standing initiative run through HHS in partnership with multiple healthcare groups. So this is what we're talking about here, and a lot of these core measures are tied to infections, not 100%, but pretty substantially, because that's one of the biggest reasons patients wind up staying in the hospital longer is they develop some sort of infection. So what we see is if a patient develops a surgical infection or a surgical site infection, they usually wind up being in the hospital about a week longer. The funny part is, and these are a little bit older numbers, but even though they wind up being in the hospital a week longer, it doesn't increase their stay that much. Now, what you do see is that these kind of bottom line patients here, the ones that are in the hospital for more than a month, have one, very poor outcomes. The survival rate's fairly low. But that's when you really start seeing fees go off the charts. So we try and avoid having patients that get an infection, obviously, but what we really try to do is prevent these kind of super infections where patients have bad outcomes and stay in the facility extremely long periods of time. So this started off in the early 2000s as the Surgical Infection Prevention Project, and that's why a lot of the stuff is targeted at surgical infections. SSI is surgical site infection. If you haven't seen that before, you'll hear that time and time again. And what they started off looking at was kind of some very simple things that we kind of take for granted, but you will still see that this is an ongoing issue, even with the revisions on top of revisions. So the first one is patients get antibiotics started within 1 hour of incision. So you have kind of a narrow window to give your antibiotics. You have at a minimum 15 minutes pre-incision and at a maximum 1 hour. So if you think about it this way, you've got to give those antibiotics time to get into circulation. So that's where the 15 minutes come in. And then on the hour side, they want to make sure that they're kind of at their peak effect. So you don't want to drag that out any more than that. Now, this is just for most of the common surgical prophylaxis. If you're using something like vancomycin, obviously we don't want to give vancomycin over an hour, so that tends to be a longer infusion. So that's kind of exempted from that. But stuff like cephalosporins, Flagyl, those sorts of things need to be given within 1 hour of incision. Um, the next thing is the antibiotic regimen is consistent with the guidelines. For a long period of time, what we saw is every surgeon in almost every hospital had their own choice of antibiotics, and it could be very different dosages. It could be very different antibiotics themselves. And the antibiotics they were giving may not have any evidence to support their use in whatever situation they were giving them. So now we see that a lot of times the hospital steps in and they kind of have an antibiotic treatment guideline or nomogram, and from there they decide what antibiotics you get for what surgical procedures, as well as outside the operating room for what types of infections. And they strongly encourage us with patients that do develop infections to quickly get cultures so we're able to use effective antibiotics to treat those. So as annoying as those blood cultures and sputum cultures were in the ICU, that's why they're so important. So we're able to use effective antibiotics. Something else was limiting how long patients were getting antibiotics. We used to give perioperative antibiotics for days and days and days, and you will still encounter situations where people are giving ANSEF every 8 hours for quite the extended period of time that's inappropriate. And what we see by doing that is that the antibiotics don't work as well, and we start to see more antibiotic resistance by doing that. So we only want to use antibiotics in appropriate doses with appropriate antibiotics and within the appropriate time frame. So why did they pick those three? One of the biggest ones was they figured out that if you were giving the inappropriate antibiotics or you weren't giving it at the right time, there was a high incidence of surgical site infections. Something we have to kind of take into consideration here is not only the time you're giving it, but what type of surgical procedure you're dealing with. For instance, if you have a patient that's having a total joint done and they're using a tourniquet, we need to make sure we give those antibiotics at least 15 minutes before the tourniquet goes up, because theoretically, as soon as that tourniquet inflates, you lose all sort of circulation there. So we want to make sure that we're giving the appropriate antibiotics again in the appropriate time frame. And then, like I was saying, if we're using antibiotics for too long a period of time or inappropriate antibiotics, there's an increased incidence of bacterial resistance. So then the next time the patient gets infected or needs to be treated for something else, they're not able to manage it with the appropriate antibiotics because they've already developed a resistance or a tolerance to it. So where did this come from? They stopped and did a pretty substantial retrospective review. As I said, a lot of this is driven through HHS, so this is CMS data usually on Medicare patients. And what you'll see is that CMS kind of sets the standard for a lot of these things, and then the private insurance companies will follow along and kind of use the CMS guidelines or the CMS measures to evaluate how they're going to pay people or not pay people. And as we know, insurance companies are obviously trying to profit and save money. So if they can find a reason not to pay someone, they're all about that. So when they looked at this, what they found was that only about half the patients actually got their antibiotics in an appropriate time frame. And we will still to this day see patients that are given antibiotics well after when they should. Now, one of the things that does pop up in some of these situations that's been disproven, but still persist, is waiting until after incision to obtain a wound culture to give the antibiotics. The wound is not magically going to heal by giving those antibiotics in an appropriate time frame. So this has been disproven, but you will still see that multiple surgeons and providers will hold antibiotics waiting on cultures. It's not appropriate for our patients and results in increased bad outcomes. So antibiotics given in that 15 to 45-minute window, there was a higher incidence of patients that were getting the correct agent, but it's fairly straightforward because most of what we're giving is broad spectrum antibiotics. So there's not a whole lot of thought involved. There are sometimes you kind of need to tailor things, especially in cases of antibiotic resistance or maybe something that's high risk like a total joint. But for the most part, the correct agent was given. And then usually it was discontinued well after the 24 hours. So, as I said, you don't want to continue antibiotics beyond 24 hours because of increased incidence of resistance as well. And this is just kind of the numbers where that came from. So you can see this is a couple years of data, and there was really very little improvement over that time frame. The one thing you do kind of see is that the timing for the antibiotics increased, but it still was not real outstanding. So why do we use this and where did it kind of come from? A lot of it was driven by that data, and their goal was to reduce the surgical complications by about 25% um, over several years. So basically, 5 years, they were going to reduce it by about 25%. Why? Because of the high incidence of complications, which results in increased loss of life, increased morbidity, and also significant financial impact. The other thing is that these were kind of low-hanging fruit. A lot of this was very easy to do as far as targeted data because it's so easily documented. It's easy for the hospitals as well as CMS to kind of collect that data. So where did it come from? A whole lot of people basically driven by CMS and HHS, or CMS and the CDC. So the surgeons were on board, the hospital associations were on board, the ASA was on board, the AORN is on board. Who do you guys see is missing from that list?
Nursing?
There's nursing on there, but who specifically is not on there? Us.
Us.
Exactly, us. We are not on there. This is a problem. We need to figure out how to become very active in our facilities because at the current rate, everything is passing us by. We will not be able to make any decisions, and somebody else is going to do it for us. So we need to be working on how we can kind of promote ourselves as a profession and kind of get on board with driving the train so we're not affected by everything else without any sort of input. So you'll see there's a lot of advocacy efforts that pop up. Little basic things like this can count. Just be on your hospital antibiotic committee. Some of them are not real sexy and sensational, but they're very important. And if you don't step forward, then somebody else is going to make decisions for you and you can't say anything. So this is what I was talking about as far as the antibiotic measures. Uh, Given within 1 hour of incision, if you have Vanc or Clinda, 2 hours. Correct antibiotic is given and then discontinued within 24 hours of surgery in time, unless the patient already has an infection. So one of the things you will see that gets done is a lot of times those patients were concerned about infection. We try and document it very early on. So, say for instance, somebody that has an open wound or open fracture, very high likelihood of those being infected initially. So, one of the things they will do is document the wound status. So, instead of it being kind of a traditional clean wound, they'll document it as contaminated or potentially contaminated, and then kind of the quality. So you can have something that's clean contaminated. So clean by virtue of there's not existing tissue trauma, but it does appear to have contamination, whether it be bacterial or potential bacterial contamination. Um, or you can have somebody that obviously has a grossly contaminated wound. And again, we want to document that. You're not penalized for infections that already exist. Where you are penalized is for infections that develop inside the hospital. So lots of facilities you see will get initial sputum cultures on intubated patients. So that way, if they have an existing aspiration pneumonia, you're not finally financially responsible. And same thing sometimes with blood cultures or sepsis alerts, those sorts of things. Of note, if you have a patient that's had cardiac surgery, a lot of times we will go ahead and extend the antibiotics out to about 48 hours. But the other thing you're seeing is a lot of those patients are being hit with kind of bigger guns. So instead of just getting ANSEF, we're seeing that they're being given vancomycin as well. Or instead of just ANSEF, they may get Flagyl with the ANSEF. So they're targeting different bacteria. Beta blockers is another one, and I'm sure you guys saw this on like all your ICU admission sheets. If you have a patient that's on chronic beta blocker therapies, they have to take a beta blocker within 24 hours of start. Now, what you saw was when this first came out, we started giving everybody essentially what they were taking. And as you can imagine, giving patients pretty significant beta blockers and then putting them under anesthesia was kind of a disaster. So the next thing you saw was that they swung to the other end of things where they wouldn't get appropriate beta blockers. They would get like 1 milligram of Esmolol or something silly. If you'll remember, like usual Esmolol dosings, 10 to 20 milligrams. So 1 milligram's not accomplishing anything at all. And then making sure that they got their beta blocker restarted after surgery. So out of kind of the gaming the system, if you will, what we figured out was really the important thing for the patient was that they just stayed on the regular beta blocker. When we start talking about home meds to continue, beta blockers are kind of an important one. This sounds kind of silly, hair measures, and I'm not talking about how they do their hair. I'm talking about how the hair gets removed. So if you think about it, if you're using a razor, not only are you removing the hair, but you're also dragging that razor across the skin surface. So when you do that, you essentially create an abraded surface, which is very high risk for infection. So one of the changes they made was we were no longer shaving people per se. They were now using like an electric clipper as opposed to a true razor. And that seems to reduce the incidence of contamination and infection right there at the site. Foley measures, this is kind of one of the ones we go back and forth with a lot of times on patients that are coming to the OR as well as patients that are kind of coming back and forth from the ICU. Um, we know that if a patient has a Foley catheter in place, there's an increased incidence of infection, whether it comes from when the Foley is initially placed or remaining in place for a long time with kind of poor hygiene. So what we try and do is one, reduce the number of cases where we're actually putting in a Foley. So previously we would put Foleys in all our lap cases. If I have a patient that's been in MPO and they can void right before I take them to the operating room, there's probably not a good reason that I need to have a Foley placed. On the other hand, if they can't void or they can't cooperate, we certainly want to make sure the bladder's decompressed so we don't put a trocar into it. But this can be problematic for you. So we're not leaving Foleys in for long periods of time. We're not putting them in if we don't need to. So with that in mind, remember that just because you don't put a Foley in doesn't mean you can't keep track of urine output. So you can use something like a condom catheter or a Texas catheter. You can also do an in and out cath. There's a reduced incidence of infection with an in and out cath versus an indwelling Foley. So kind of the takeaway from that is that there's a high risk of infection, and that if we're going to have a catheter in place or place it, we really have to document why, whether it's on our side or on the surgeon's side, to make sure that we're kind of proving the point of why it needs to be there. One thing you'll figure is a lot of this data is collected by what I call nurse trolls, that really have nothing else to do but go around and kind of make your life miserable and jump out from under bridges and ambush you with numbers. Try and avoid that if at all possible by checking your boxes, making sure everything's squared away. And part of it is this Foley orders or taking the Foley out. Sugar measures. If you've ever worked in the cardiac ICU or done like tight glycemic control, you know how exhausting that can be. We've kind of waxed and waned a little bit on this, but for a while there, we were doing very tight glycemic control. We were trying to keep patients' sugar between like 100 and 120, even doing like insulin drips with Q15 or Q30 minute blood glucose checks. We figured out that even though that seemed to be doing a good job, that it was probably excessive. So we've kind of backed off on it a little bit. But especially in cardiac patients, we want to make sure that we have their sugar somewhat controlled because high glucose levels contribute to infection rates. So we try and keep their sugar under 200. Some places suggest 180, and then keep it there. This can be problematic for us in the operating room for several reasons. One, you've got to find some way to check a finger stick. On the floor, it was really easy. You had glucometers available to you. You may not have that in the operating room. And then the other thing is, even though you have a glucometer or you get it from pre-op or you get it from PACU, you may not be able to physically run that test. So you may be dependent on somebody else doing it for you. I've worked at multiple facilities where we were running ABGs to get glucoses because that was the only way we could check it. Definitely not a great idea, but that was the only way we could do it using that system. DVT measures, obviously, we don't want patients clotting off inappropriately. So if you're doing a general surgery case, or excuse me, a general anesthetic that lasts more than an hour, they need to have SCDs placed. Notice I said SCDs, not TED hose. TED hose have been somewhat disproven as far as being effective mechanical prophylaxis. So SCDs placed for all general anesthesia procedures over an hour. They need to have some sort of appropriate DVT prophylaxis on their admission orders. And that's not only mechanical prophylaxis, but pharmacologic prophylaxis as well. So lots of times what you'll see is they'll get a one-time dose of heparin. Now, obviously, there's some patients that's inappropriate for patients that are at high risk for bleeding or actively hemorrhaging. We don't want to make that worse, so we'll hold off on them. But then you just have to document why you didn't give the anticoagulants. And I would certainly still consider other methods. You know, maybe we're not going to use any sort of pharmacoprophylaxis, but we could do mechanical prophylaxis for the patient. And then ultimately making sure the patient's getting those medications and continuing them for some time after surgery. This is a big one for us, and I think you guys can probably remember every patient that came back to the ICU after the OR was cold. But this was added kind of in the second iteration of Scip. If you have patients that have been under general anesthesia, they need to be normothermic or documentation of active warming in the OR. So for the first temperature you get in the PACU needs to be over 96.8. And the other part of that is how is that temperature obtained? and then what was done with the patient. So, say for instance, you had somebody that had hypothermia induced for cerebral protection. Obviously, I don't expect them to be normothermic immediately post procedure, but I need to document why. The other part of that is sometimes patients come in hypothermic and we may warm them up, but it wasn't possible for us to get to a normothermic temperature. So, somebody comes in and they're like 93, 94, and I get them up to 95. I've done a great job. I've taken them up 1 to 2 degrees, but I'm not within that desired temperature of 96.8. So I need to make sure I document that. Other considerations, how the temperature is obtained. We've kind of gone away from getting true core temperatures anywhere in the hospital, and what you see is people either use those forehead scanners or like an axillary temp probe. Oftentimes, those will be up to a degree off. So it doesn't seem like a big deal, and it didn't matter to you when you were in the ICU because you were just hitting on anesthesia by dropping the temperature down. But if your financial means are affected by whether or not you delivered a patient that was appropriately warm, you want to make sure you have a good temperature. So part of that is if you're taking somebody back to the ICU and they have a temperature probe in place, make sure they're using the temperature probe. Sometimes it's just a matter of them having the cable. Sometimes it's just being difficult. Sometimes there's an actual agency or a facility guideline that says this is how the temperature is obtained. But just remember that a lot of those temperature methods may be inappropriate for patients that have been under anesthesia. For instance, when a patient's under general anesthesia, oftentimes their head is exposed. So their whole body is covered up but their head. If you use that temporal thermometer, it's obviously not going to be accurate. Other things, like if you have somebody that's vasoconstricted or on vasoactive medications, you may notice that you're not getting accurate axillary temperatures because they are vasoconstricted and relatively hypoperfused. So make sure you get good temperatures. Um, this was a study that kind of went through and looked at all the patients that across the country that had certain procedures done. And what they found was that the kind of individual measures weren't so big, but overall, there were some big issues they looked at. So the big thing they found was looking at patient temperatures. Now, notice this was documented in an anesthesiology journal, so you can see how important it is to us because this is one of the biggest core measures that affects us solely. The hospital is not really evaluated on the basis of their temperature nearly as much as we are. So, other things you see that come out of this is what are we doing to keep our patients warm? You will see oftentimes, in addition to keeping the patient warm in the operative period, we're doing things like pre-warming. We're making sure they get a warming blanket applied in PACU. At our facility, Bear Hugger, who makes our kind of warming products, makes a gown, and we just hook them up to a Bear Hugger out in the pre-op area, and then that gown follows them all the way through their operative time. So this is kind of a summary of the latest version of Skip, and a lot of this is the same stuff we've talked about. But prophylactic antibiotic use in appropriate time frame, the correct antibiotics, discontinuing them, beta blockers, how hair is removed, Foley stuff, blood glucose management, SCDs or DVT prophylaxis. So all that sounds pretty familiar. Any questions on skip stuff? Like I said, it's kind of common sense, but it's also stuff that you may not have evaluated in quite the same light before because of your position. All right, so we're going to kind of transition from Skip to Eras and kind of considerations as far as surgical procedures. So Eras is enhanced recovery after surgery, and this is basically a systematic method to ensure that our patients have improved outcomes. And it started off with GYN surgery and colorectal surgery, and it's kind of expanded out from there. A lot of facilities have widely adopted this, but not everywhere. So you may see when you get to clinicals, the things you're talking about, even though they're, 5+ years old for some of these things, still haven't been implemented, and they look at you like you're crazy. Because some of these things are kind of a step away from what we've always done. So we're going to go back in time to 2002. Some of you may not even have been walking or talking at that point, but we thought we were really cool. We got the first electronic gadgets, the Palm Pilot, the iPod. If you're a Star Wars fan, Episode 2 came out that year. But we look back now and we laugh at some of these things that we thought were really cool. A lot of the anesthesia practices are the exact same way. So we're going to talk about kind of a specific patient to highlight some of the things we're worried about. So typical male coming in with colon cancer, he's here for a colectomy. Uh, Patient had his history and physical done with the surgeon. They made sure he was NPO after midnight. So, what does NPO really mean? We have the appropriate guidelines that we see here, and then we have the kind of catch all. And there's a couple of different things that go into that. Part of it is that patients don't follow directions. So, when you tell somebody it's okay to drink clear liquids up to 2 hours before your procedure, next thing you know, they're drinking milk, they're eating little foods. So a lot of times you will still see that we kind of follow absolutes. So we give people kind of blanket times like nothing to eat or drink after midnight. Not saying that it's not appropriate to do something else. We just assume the patients can't follow the directions. But unfortunately, we're doing the same thing in the hospital. How many of you had patients that were going to the operating room the next day, and instead of following the appropriate guidelines, they said NPO after midnight or needs to be NPO for 8 hours? As you can see here, there's very few things you truly need to be NPO for 8 hours, but that's the most common standard of time we see being used. So I would make sure you know these numbers. They tend to pop up pretty frequently. So morning of surgery, the patient comes in, they get the H&P updated. They explain to the patient what general anesthesia is, what happens in the operating room, what happens afterwards. Um, this facility uses some pre-medication, so they got some Versed and fentanyl. And this is really when we first started doing some kind of PO pre-meds for patients. So a lot of these patients were getting Celebrex or Vioxx. Um, the COX inhibitors were kind of a game changer for a lot of these patients early on. And I think you can have some discussions about which medications you're using and when. But it was kind of nice that we started thinking about something other than just IV medications for these patients. So there's a large variety of pathways that we deal with that affect pain. And there's a couple different ways we can intercept them. So we can do it peripherally, we can do it centrally, or we can affect some sort of transmission in between. So the patient got to the operating room. They were placed under general anesthesia. We started giving them fluid. At this time, we were using kind of the 421 rule as far as fluid evaluation. There was nothing evidence-based or nothing patient-specific. It was just follow the 421 rule. Some things that kind of came into play, we used to do bowel preps on everybody. So when you do a bowel prep, as you can imagine if you haven't had it before, you lose huge volumes of fluid. You're profoundly dehydrated by the time you get to the operating room. So before we even introduce any sort of anesthetic, you're already having volume issues. And then after that, he's having a colectomy done. We open up his whole belly, and now there's significant evaporative losses from that. So you can see how we're kind of setting ourselves up for a bad situation. PONV prophylaxis was very all over the place. There was no standard. The patients weren't evaluated. People just gave whatever they commonly gave. At this time, Phenergan was extremely common, as was Compazine. We didn't really think about how it worked or what receptors it was working on. And then pain management was also kind of all over the place. A lot of times we saw things like morphine or long-lasting opioids being used that may not have been the most beneficial for the patient. So if you haven't seen the 421 rule before, this is how it works. So what you do is find out what your patient's weight is. And for the first little bit, you use 4 mLs per kilo, and then 2 mLs per kilo, and then 1 mLs per kilo to figure out that this patient basically has a need every hour of 110 mLs an hour. And then you multiply it times however long they've been in PO. But this doesn't account for things. So, like I was saying, you got somebody that's got a bowel prep. They may have lost a pretty significant amount of fluid there. So, we can't really account for it. You kind of have to let the patient drive it, but it can be problematic for you. And then we open up the patient. Now they start to have evaporative losses, which can also be pretty high. So just to kind of look at it from this standpoint, we were doing 110 mLs an hour, and then we're adding to it 3 to 600 mLs. So pretty significant amount of fluid going into this patient every hour, and that's without even taking account for any sort of bleeding, any other problems that they may be able to get into. So definitely something to think about. So Make sure you know the 4-2-1 rule. Like I said, 4 mLs per kilo for the first 10, 2 for the next 10, and then 1 for everything over 20 kilos. So, what's the problem we see if we're giving all these crystalloids? One of the issues we run into is that there's a high potential of fluid overload. We may create a relative dilutional anemia because the patient hasn't lost any blood, but we've put more fluid into it, kind of the closed space. So that can be problematic for us. We can have anemia, we can have bowel distension, none of which are good for the patient. So at the time, we did a ton of opioids. That continues lots of places to be our go-to. But now we're starting to see over time that surgeons may be able to do little things like just infiltrating a site before you put a port into it. Goes quite a long way. Other things, we were using a large number of thoracic or lumbar epidurals for these procedures, but what we found was that we had a lot of trouble getting them placed. The failure rate was not very good because it was hard to evaluate. Because you put this epidural in and then almost immediately induce general anesthesia. So it's not like an obstetrical patient that's laboring for hours and you can kind of evaluate whether it's working or not. So that was not such a great situation for us from that standpoint. Another issue that came into play was what was the facility really able to manage? So you have somebody that gets up on the floor, they've got an epidural in place, and now they're weak. Meanwhile, somebody's trying to get them out of bed or they're trying to get to the bathroom because the bowel prep is still striking them, and that can be problematic for you. So definitely something to be careful with there. Thoracic epidurals can be a little bit more challenging. One, by virtue of the fact we don't do it very often. By two, the angle of the thoracic spinous processes is significantly more acute than that of the lumbar processes. So concerning for us, you also have a much larger potential space, so that can be problematic as well. Um, Other things that we started slowly thinking about, Ketorolac or Toradol. We figured out that it was able to help us reduce the opioid requirements for these patients, but there were some concerns. One of the biggest ones that gets raised by surgeons is the risk of bleeding, because it does affect the platelet function a little bit. But what we found is that giving like lower doses, like 15 versus 30 or 60 milligram, and only doing it once or only doing it for a couple doses is fine. Where we were getting in trouble is when it first came out, we would do like X amount every 6 to 8 hours and then repeat it for like 4 or 5 days. And that's where we saw problems with coagulation. Kind of the same thing with kidney injury, though we tend to be a little bit more cautious about kidney injury. Other things to consider as far as pain management, dexmedetomidine allows you to reduce the opioid requirements, quite the synergistic effect. And then ketamine works very well for these patients as well. Other things to think about from an intraoperative standpoint, anytime you have a patient that's having a bowel procedure or an abdominal procedure and you're putting in a gastric tube, put in an NG tube. And the reason I say that is there's a pretty decent likelihood that the patient may need to retain that NG tube at the end of the surgery. Most of the time, if we put in a gastric tube in the operating room, we just put in an OG tube, but nobody wants to go back to the floor of the ICU with an OG tube in. It's not very comfortable. So if you're going to do it right the first time, put an NG tube in. We will also oftentimes put this to suction to allow us to decompress the stomach before the surgeon starts putting trocars in and pokes a hole in something important. So that's something for you to be careful with as well. And then talk to the surgeon. In the past, we put NG tubes or OG tubes in everybody, but now we've kind of backed away from that. So is this a case where we really need it? Other things from our standpoint, it may be necessary, not because of the surgical procedure, but maybe I need to decompress the patient's stomach beforehand. I'm worried they may vomit and aspirate on injection. So that may be some or a reason I put an NG tube in. Appropriate antibiotics, we've talked about the importance of that, as well as keeping the patient warm. Something else for us to think about that's a huge dissatisfier for patients, but also tends to cause us problem and is one of those kind of easy core measures for the hospital to evaluate is PO and V. So there's a scale for it, and we'll look at the scale here in just a minute. But what you'll find is because it's such a huge dissatisfier of patients, that especially in patients that are high risk, we go ahead and give multiple antiemetics. So things that are kind of increased risk for you, being female, This is one of the few things where smoking is actually good for you. So being a non-smoker increases your risk. Young patients tend to have more problems than old patients. Patients that have extended anesthetics have more problems. If they're going to get or have gotten opioids, that increases your risk of PONV because it decreases your gastric progression. And then the big thing is if they've got a history of PONV, it's probably not magically going to get better in the operating room. So these are the biggest things that people complain about as far as from a PONV stand or from an anesthesia complication standpoint. So if you stop and look, one of the biggest ones they worry about is vomiting, even more so than pain, even more so than waking up and gagging on the endotracheal tube. So nausea and vomiting are pretty big dissatisfiers for patients. So with that in mind, I tend to treat it pretty aggressively. So there's a couple different things out there you can use to evaluate. This is a pretty common one. This is just the Apple scale, and what it looks at is risk factors for nausea and vomiting. So, like I said, being female, not smoking, history of POMV, and then getting opioids. So, scale to 0 to 4. Generally, we consider patients that have two or more risk factors to be moderate to high. Patients that get a 0 or a 1 are not quite at the same risk. But with that being said, even if it's not necessary, it may be worthwhile to go ahead and give them antiemetics to reduce the incidence of PONV complications. So in PACU, we give these patients more fluid and more fluid because they weren't edematous already. So then we start trying to work on other things, getting them warm because they're freezing and we've had their bowel hanging out. So getting them warmed up. And then how do we manage their pain? We're going to give them some more opioids because that's what we use with everything. And then these patients, instead of getting any sort of targeted medication therapy or nerve block, would get a PCA, which they would take to the floor. So we've changed a little bit over time, gone into the Palm Pilots, and here are the iPhones. We got new Star Wars movies. And Eras kind of comes onto the scene. So Eras is really a systematic means of providing kind of the best possible outcomes and management for our patients. One of the important things for you to note with this is that it really involves the whole team. It's not just one provider. And you can find that if you are that one provider trying to do it someplace where they don't have kind of a culture that supports this, it can be extremely frustrating for you. So these are kind of the time frames as far as the phases of care. So pre-op is kind of the decision to have surgery to the night before surgery. So this means preoperative evaluation meeting with the surgeon, and everything kind of up to the night when you go to bed before surgery. Intra-op starts on the morning of surgery, carries obviously through the intraoperative period and then to PACU. And then on the backside, we have when you leave PACU, if you're in the hospital for a while after that, and then when you're discharged. And part of the reason we talk about that is the things we have to consider vary greatly from one step to another. So in the pre-op period, one of the biggest things we need to do is assess our patient for risk and figure out if there are any medical complications we need to address. Doesn't sound too different than what we do for every other patient. One of the big things here is we need to focus on interventions for us in patient education. So telling the patient that I need them to drink a Gatorade on the morning of surgery is very different than what we've always talked about. You know, they wonder why you've always told them to not have anything to eat or drink after surgery or before surgery, but now you're telling them to have a Gatorade on the way to the hospital. That doesn't make sense to them. So you need to explain why you're doing these things. Sometimes you not only have to educate the patient, but you have to educate other people in the hospital. The pre-op nurses, try and try, but sometimes they don't understand what's going on or they have like misconceptions about it. In the intraoperative period, like I was saying, we may want to limit the fasting. So if they really only truly need to be NPO for 2 hours as far as clear liquids, let's have them continue to take clear liquids. Keep their bowel function intact when they go to the operating room. Don't make them NPO for hours and hours and hours. An additional change is the addition of a carbohydrate-rich beverage. Commonly, what you're seeing is Gatorade being given, so they'll have a Gatorade like 2 hours or like right at the 2 hour cutoff before surgery. We're trying to operate by reducing the opioid requirements and utilization by using multiple different medications. And then we need to also continue those medications not only through the OR, but also into recovery and onto the floor. So that may involve some action on your part, kind of communicating with the surgical team what you're using, what you're not using. And then on the backside, things that seem very simple but make a huge impact on patient safety. getting them up out of bed within 8 hours. Oftentimes now we're seeing that these patients are getting up in PACU and walking around. So these are some examples of things that we need to assess on these patients in the preoperative phase. A lot of this has come from, you'll see there's kind of boutique hospitals that focus on certain things like joints or backs. Because they're in the business of having good outcomes and maximizing money, they tend to be very aggressive as far as managing a lot of these issues. Formal patient education. This is a huge one. I can't convey enough how little patients understand about what we do and why we're doing it. Um, One of the big areas that our facility gets dinged on is patients not understanding their anesthetic. So what can you do? Can you put together a video, a handout, sit down and talk with them? Sit down and talk with the surgeons about, why you may need to do one anesthetic over another, because oftentimes they don't understand. I can't tell you how many times I've heard surgeons say the patient needs to have a general with an LMA. There's functionally no difference between a patient having an LMA general anesthetic or an endotracheal general anesthetic. They don't understand it. They just think that somehow LMAs make things magically happen faster. Good anesthesia providers make things happen faster, not using LMAs. Other things to consider, we need to make sure that everybody is on the same page when we're doing this. So one of the big issues we run into is that, especially if you're dealing with different surgical practices, that, Dr. Brown's doing it one way and Dr. Smith's doing it another. We need to make sure that everybody is on the same page as far as how they're managing these things. And like I said, that needs to start in the preoperative period. Otherwise, we just don't have good outcomes. It's very hard to do a lot of these things if they show up the morning of and you're trying to play catch up. So risk assessments are important. We need to figure out what we can do to kind of optimize the patients. And when we think of optimize, we usually think of physical, but there's also a pretty significant functional and mental component that goes along with it. There's a pretty strong program out there from the American College of Surgeons. But like I was saying, a lot of these facilities have their own policies. You just have to find them. So these are some things that patients can do to prepare them for surgery. So if you have a patient that comes into the preoperative clinic to be evaluated, even if these don't affect them, these are things they can think about doing when they go home. So if you've got a diabetic patient, the screening tool on the right is pretty helpful. For pretty much the general population, the one on the left is pretty appropriate. These are some different risk assessments or screening tools. You'll notice these are very objective. BMI is easier to figure out. Patient age is figuring out, are they smoking or not smoking? All those things are kind of helpful when you have standard values. During the during the intraoperative phase, like I was saying, a limited MPO time and a carbohydrate-rich beverage, getting your kind of Eras cocktail going early. So PO medications are pretty beneficial. Not using Foley's if you don't have to. What can you do to minimize blood loss? Can you do minimally invasive surgery? Can you give something like calcium or TXA, any of those sorts of things? And then outside of that, it sounds kind of easy, but just keep everything normal. Keep their volume status normal, the temperature normal, their sugars normal. Treat them for potential nausea and vomiting. And if the Foley is placed, you'll see lots of times we take this out in the PACU or we take it out right before we take the patient upstairs. This isn't to piss off the nurse. This is to try and reduce the risk of infection. So one of the things we see is that surgical stress and NPO are kind of a horrible setup for patients when they're in the perioperative period. So as a result of the surgical stress, we see that there's an increased incidence of immunosuppression and patients already become insulin resistant. The glucose is not uptaken in the traditional pathway, so it makes our sugars a little bit higher. There's an increase in gluconeogenesis, catecholamine surge, and levels of a variety of circulating hormones. So that's bad on one side. On the other side, what you see is they tend to have an increase in lean tissue loss. They tend to be in bed longer. They don't mobilize well. They get wounds that just won't heal. So all those can be problematic for us. So it's important for us to not only control surgical stress, but also glycemic index. So this is just some information as far as like the carbohydrate loading. What they found was that using the carbohydrate drink significantly improves the insulin resistance. The patient's word is hungry and thirsty. I can't tell you how many patients they finish surgery and they're not complaining about pain. They just want something to drink. So little basic things like that can go a long way. They didn't find any sort of differential as far as preservation of muscle mass, and there wasn't any sort of increased aspiration events. And that's a big one because one of the biggest concerns that people have when we start talking about giving carbohydrate beverages 2 hours before surgery is that there may be an increased risk of aspiration. That doesn't seem to hold true. So this is kind of a flow chart that helps you figure out when to give medications and when to give what medications as far as multimodal stuff. So things like gabapentin really need to be given up front. You can use NSAIDs and opioids throughout any part of this period. So you'll see commonly what happens is that we will give the patient maybe one medication at one point, one at another point. Um, Tylenol, in spite of all the publicity, gets used frequently in the perioperative period. You'll see oftentimes this is given up front, and then if you have longer cases, it may be given again. When you're using Tylenol from a financial standpoint, PO Tylenol is fairly cheap. IV Tylenol is not as expensive as it once was, but it's also not cheap. So if I can save some money and I'm gonna have you take some pills anyways to get your gabapentin in, it may be beneficial to do PO Tylenol up front. Dexamethasone, usually given post induction to help with pain as well as nausea and vomiting. So kind of a nice beneficial drug for multiple patients. A caution if you do have diabetic patients, there will be a slight increase in surgery related blood glucose. So be careful as far as how much Decadron you're giving them, especially if you have a truly brittle diabetic. You may want to consider dropping that dose down to 4 mg instead of 8 mg. Muscle relaxers, when we talk here, we're talking about things like Robaxin, not skeletal muscle relaxers like Vecuronium. But those can be given at PACU and then when the patient goes home. And then at any point in here, you can always rescue the patient with IV opioids. There are some other options, but that's kind of our go-to for things. So as far as medication dosages, this is an example of the Eras protocol from Cleveland Clinic. As I said, a lot of places have kind of standardized this, so you'll see that these are maybe on order sets or they're something easy to find. So morning of surgery, some Tylenol and gabapentin. A caution for you as far as the gabapentin goes, we do see in older folks that they tend to have a little bit of somnolence, sedation. So probably consider reducing the dose to like 200 or 300 mg for them. Right before incision, we can give a bolus of ketamine for pain. Lots of places will do an IV infusion as well as a bolus. So you give the bolus to get to a steady state, and then you continue with an infusion. And that goes for ketamine as well as for lidocaine. If I'm in a situation where I can't do a peripheral nerve block, a lot of times I'll run a lidocaine infusion for those patients. You can still infiltrate at the port sites. Most of our patients are pretty healthy size, so there's not real high risk of kind of reaching that ceiling limit for the local anesthetics. Post-procedure, you can use fentanyl, morphine, small boluses to try and just keep the patient comfortable to a manageable level. Remind them they're probably not going to be pain-free. We just want manageable, realistic pain. So post-op, try and get them up and out of bed as soon as possible. If they sit in bed, there's an increased incidence of complications, bed sores, DVTs, all sorts of bad things come out of it. They need to eat, especially if you've got somebody that has poor nutritional status at baseline. They're not going to get better if they're not eating or getting tube feeds. So try and get that started as soon as possible. Follow up with these patients. Anytime you do something different, go to the floor, see if they did well. Because otherwise, we'll go for years and years and years and do these things and have no clue that it's not beneficial for our patient. So make sure you're following up with them at some point in there. So we've changed a little bit in our approach to fluid management. One of the biggest things is we've kind of gone to goal-directed therapy. So a lot of times what we're doing now is using non-invasive technology to evaluate it. So things like the FlowTrack, the Cheetah, the ClearSight, all of those help us evaluate our volume status. So we're not just dumping lots of fluid into these patients. Be careful if you're using crystalloids, avoiding saline if possible. And there's the potential that we may have a greater role for colloids in these patient populations, especially if you're concerned about how much fluid you're giving them. If you've never seen some of these non-invasive monitors, there's just a variety here. Some of them are pretty cool and provide you essentially the same information you get in a PA catheter. So if you haven't seen them before, I would certainly take a look at them. There are some potential errors with them, but I think it's definitely better than nothing. And it may be preferable to invasive access, especially in somebody that's problematic. So one of the things that's come up is that we still need to do a bowel prep on these patients. Part of that came out of concern that we would have bowel spillage into the abdomen when we were doing a resection. That's turned out to not really be true. Even in urgent or emergent patients coming in for colorectal surgery that have not had a bowel prep, they don't have an increased incidence of infection either. So what the studies found was if you didn't have a bowel prep, you're able to have earlier return of bowel function, which makes sense. They don't have that period there where they're not working, and then you get out of the hospital faster. From our standpoint, there's a pretty significant decrease in the amount of fluid you've lost. So things that we found when we started doing the carbohydrate loading, like I said, up to 2 hours before surgery, there was no increased incidence of aspiration, so that's good because that was a big concern for us. The patients aren't as hungry and thirsty. Insulin status is better. Interestingly, they're able to retain their muscle strength and lean body mass better, even as little as one drink pre-procedure. So it's kind of crazy how that carries over. As a result of that, they tend to get out of the hospital a little bit faster. So this is evaluating how we're administering pain techniques to our patients, and what they found was longer lasting opportunities tend to do a little bit better versus PRN stuff. And this is something I say all the time. We're a lot better if we can get the patients to kind of a steady state period as opposed to peaks and valleys. So if you're doing spinal opioids or some sort of regional technique, it's definitely preferred over PRN opioids. So problems we run into with opioids, one of the big ones that we've talked about is that nausea and vomiting is a huge dissatisfier. Opioids are a trigger for nausea and vomiting on top of everything else. So if you look at the data, you'll see that there's an increased incidence of nausea and vomiting in a lot of these techniques, even if you put your opioids in a spinal or an epidural. So just be mindful of that when you're managing patients. Other things we need to consider, multimodal pain management. So, depending on your facility, you may find this is a little bit of a challenge for you. Some facilities have embraced multimodal management with open arms, so patients are getting like preoperative meds that help out with that. Other places it can be really difficult. I've definitely worked in facilities before where I had to go get the pills out of the Pyxis or call the pharmacy 19 times and walk to wherever the patient was to give them to them. It shouldn't be that way, but it still happens. These are some of the examples of things you can use to intervene at various levels, whether it's in the periphery, in the transmission system, or in the cortex. These are some amazing facts on what works and how well it works. So things to think about, like I said, even as basic as it is, Tylenol, other NSAIDs are pretty beneficial. Ibuprofen works well. You'll see that there's a lot of times we will hold ibuprofen over kind of contraindications or concerns. So just be aware of that. Ketamine tends to be a little bit, or excuse me, acetaminophen tends to be a little bit more innocent. Other common medications we use for pain, ketamine, dexmedetomidine. If you can do something like a neuraxial, epidural definitely works pretty well as long as it's in the right hands. And then stuff like giving gabapentin and corticosteroids helps out as well. So for patients with thoracoabdominal stuff, examples of what we can do in terms of regional anesthesia, a rector spinae block, or transverse abdominal plane block. Personally, I prefer ESP because I have solid landmarks. If you look at that picture on the bottom left, that's the tap block. Right side, you're looking at the ESP. You can certainly consider an epidural for these patients. It may be more problematic depending on where they are in their journey. But other things you can do, if you come back and look at this tap block, what you'll see when you do a tap block is you tend to get a little bit more as far as like somatic innervation. It's still going to be dorsal nerve root, but you'll get somatic innervation, which may not help out so much with the inside of the peritoneum. It tends to be more of the skin and those sorts of things. So if you're concerned about your patient having pain, you don't necessarily have to do a tap block. What you can do is what's called a quadratus lumborum block. So this allows you to hit that nerve root a little bit closer, and it provides you with sensory or visceral as well as somatic coverage. So when you do a tap block, all you're going to do is locate kind of the muscular structures of the abdomen. So you locate the external oblique, the internal oblique, and then the transverse abdominis. And you're just going to come down in this fascial layer and put some local there. This is just a potential space. You're not actually seeing the nerve there. So, it's kind of like a shotgun approach. We know the nerve is supposed to be there. We don't see it. But this is sometimes why patients will have pain afterwards. Maybe we didn't see the actual anatomy, or maybe we didn't have good needle placement. But definitely easy block to do, worth remembering. And this is just an example of where you would do it. So things to think about as far as Iris goes is you've got to start this early. Like I said, it's a continuum, so they need to understand all the steps in the process. Everybody needs to be on the same page. So preoperative counseling is a huge part of this, as well as education. In this day and age, patients have so many questions that we don't answer, the surgeon doesn't answer, or the anesthesiologist doesn't answer. And most of them are going to get on Google and see what it says. If you've ever looked for medical information on Google, it can be kind of scary. I think like half the time you have cancer and you're dying, and it's really just like a stubbed toe. I can't emphasize this enough. Continuation of clear fluids until 2 hours before induction of anesthesia. Also, think about your patients on the ICU or patients that are on tube feeds. When do we really need to turn those tube feeds off? They may be able to continue that to 2 hours before the procedure as well. Oftentimes, what you'll see is those patients need healing ability, and if they're not getting nutrition, they can't heal. And we keep turning it off, turning it off, and turning it off, and they're not able to get any sort of nutrition. Remember what the actual guidelines are. So there's a ton of stuff you can use for PONV. This kind of little chart down here at the bottom shows you a ton of different receptors, a lot of different ways you can manage it. My kind of standard go-to for most patients is 8 of Decadron and 4 of Zofran, and I will expand out from that. So if I have somebody that's kind of an increased risk above that, I may give multiple doses of Zofran. We worry about giving more than 4 milligrams that it's going to cause some sort of cardiac issue. Very rare. And then on the other hand, if you watch patients like chemotherapy patients, they'll be getting like 20 milligrams of Zofran at a time and like 20 of Decadron, stuff like that. So don't worry too much about how much of those medications you're giving them. But these are some ways you can kind of hit the receptors and you can also address specific concerns. So things to think about intraoperatively for patients under urus: keep them warm, keep their pain under control. Avoid routinely putting in G tubes in patients unless you need to. Not saying don't do it, I'm just saying have a reason for it. Um, if we're not appropriately managing these patients with goal-directed therapy, as I said, we can cause lots of problems, bowel edema, infiltration, tons of stuff. Um, Avoid giving patients long-acting opioids. And if you do, give them something that's kind of middle of the road. So not something short acting, not something extremely long acting, but kind of an intermediate acting, so they're able to see how they feel and kind of respond to that. So what are the problems we run into? Um, Usually they're people problems. There are some logistical problems, but it usually is people that get in the way. Um, what you'll see is when you go someplace and you've always done something some way and it's different than what's being done there, you are wrong until proven otherwise. So you'll see with a lot of this IRIS stuff, those same things happen. If somebody hasn't actually seen an IRIS protocol working or doesn't understand, they're going to think you're crazy until you show them otherwise. So big improvements as far as outcomes for the patients: reduced morphine equivalents, improved pain scores, and out of the hospital faster. All the things we want. Um, Now, this is an interesting one. You know how I talked before about CRNAs not really doing much? This is something where we've kind of stepped up to do a little bit better. I'm going to share this with you. So this is just a brief guide, and there is kind of some expanded stuff out, but this covers a lot of what we talked about anyway, as far as like fluid management, pain management, how IRIS can help reduce length of stay in the hospital, how it can balance out from a financial standpoint. So this is kind of cool that our professional organization actually did something with that. And then this is their practice guide. They have a bunch of clinical practice resources. So covering everything from Eras, like we're talking about now, to malignant hyperthermia, marijuana, dental anesthesia, all sorts of stuff. So if you've got a little bit of time, I would go take a look here. There's some pretty decent guidelines in here for patient management, and they take it down into a whole lot of steps. So if you happen to go to a facility and you're the one that's kind of implementing for the place, there's some great guidance there for you. All right, that's what I have. What questions do you guys have about that? I know a lot of that's fairly straightforward, but some of it is very different than what you've probably been told for quite a while.